onto the calcaneus appears relatively normal. The patient had corresponding sonopalpatory pain at each of these locations, reinforcing their clinical significance. For persistently symptomatic proximal plantar fasciopathy, a variety of treatment options have shown success. I typically begin with an ultrasonic percutaneous tenotomy. In cases of mid-substance plantar fasciopathy, it's important to differentiate it from a plantar fibroma. Compared to proximal plantar fasciopathy, there is limited clinical experience with treating mid-substance involvement. I have used percutaneous tenotomies and orthobiologic injections with varying success. When evaluating proximal plantar fasciopathy, it's important to assess for a tear. To do this, I perform dynamic plantar and dorsiflexion, which often better reveals the extent of the tear. Most commonly, these are central undersurface tears located adjacent to the enthesiophyte. The long axis cineclip on the left demonstrates a dynamic maneuver showing the partial thickness tear stretching further during dorsiflexion. This raises the question of whether aggressive stretching should be included in rehabilitation protocols, as the tear visibly enlarges with ankle dorsiflexion. The short axis image on the right shows the central location of the tear. While performing a dynamic study, I also assess for signs of insufficiency where the central cord fails to tighten adequately with dorsiflexion. The long axis cineclip from a patient with symptoms of proximal plantar fasciopathy shows the typical appearance of a high-grade partial thickness tear. With dynamic dorsiflexion, the central cord does not tighten to the normal degree, indicating significant structural compromise. Additionally, the optimal treatment approach for these symptomatic tears remains unclear. Returning to the protocol, it's important to assess for coexisting diagnoses with plantar fasciopathy or an alternative diagnosis. This next case involves a 51-year-old runner with plantar hindfoot pain clinically diagnosed with plantar fasciopathy. There was no improvement with a palpation-guided corticosteroid injection. The long axis image on the left shows a normal appearing central cord. The short axis cineclip on the right shows an area of well-demarcated fat pad thickening and increased hypoechogenicity consistent with a plantar fat pad bursopathy, nicely outlined with dynamic transducer compression. The histology is similar to a submetatarsal bursa in the forefoot area, consisting